There, that's the front one. Hi, I'm really honored to be here. I cannot claim to be even remotely as highfalutin as most of the people have spoken. I am your boots on the ground here. I'm a retired family physician. I live in Portland, and my practice included lots of obstetrics, so I cared for many families and people of all ages. I always felt that aid in dying might be appropriate under, wow, you're getting, I'm done. I've always felt that aid in dying might be appropriate under some circumstances, and I had a few patients request it before our law went into effect. I never acceded to a request back then, and those cases distressed me. And a little bit along the lines of earlier discussion, a couple of kind of messy suicides were included in those. After our law went into effect, I was known by Compassion & Choices to be willing to accept referrals to consider aid in dying. I turned down their first case because of medical requirements, but the second patient they asked me to see became Oregon's first legal aided death case in March of 1998. In the next 13 years, I wrote about 25 prescriptions. About 15 of my patients used their medication for a planned death, and I was present for 3 of these deaths, including the first one. After I retired from medical practice, I worked for Compassion & Choices for a couple of years advising doctors in Oregon in the use of the law, and I also did some work advocating for similar laws in other states. For the last 20 years in Oregon, we have no longer been debating about whether aid in dying should be legal. This has allowed us to concentrate on how best to address the desire for it. We've all developed more experience in evaluating whether patients are qualified for aid under the law, and we've also had more freedom to explore open questions, unexpected consequences, and uncommon outcomes. I support Oregon's aid in dying law, especially because of the enhanced communication potential with patients and families. But I'm not here to advocate. I'm here to examine some of the harder parts and thoughts for improvement. But first, the single sentence summary is that in 20 years and 1,500 cases of aid in dying in Oregon, there's not led to any complaints of misuse to the Oregon Medical Board and almost no unexpected complications. Second, there's a fair amount written about how to respond to requests for aid in dying, whether or not the practice is authorized in a specific jurisdiction. In authorized states, the law usually mandates some components of the conversation, verifying a patient qualifies about age, state of residence, decisional competence, life expectancy. The law also often requires listing alternative palliative treatment options, emphasizing a request can be rescinded, recommending family be notified, and ruling out coercion. And aside from legal mandates, there have also been a lot written about the ethical considerations around discussing aid in dying with a patient. And these might include discussing the meaning of the request, attitudes about what in life the patient especially values, etc. But I think that the most important pearl in evaluating a person for aid in dying is not discussed in published literature, and this is the most important thing I'm going to say today, which is that the key is to talk with everyone involved: family members, friends, caregivers, hospice workers, other clinicians, your consultant physician. Look for consistency of request over time from various points of view. And the more time you spend with trusted people around the patient, the easier it is to feel comfortable with your eventual decision. Before writing the first prescription, I spoke at length with the patient, each of her 2 adult children, both of her previous physicians who'd been unwilling to consider prescribing, 2 hospice nurses, the hospice social worker, and the consulting physician. I also made a house call to discuss it further in the family setting. It always helps, even if the patient's usual healthcare system or doctor will not think about providing the service, because they can still provide valuable perspective on whether the patient would qualify. It's very important, I'm going to underscore this again, very important to avoid prescribing if there's any real disagreement about whether the patient qualifies. I would like to underscore here that this rather amazing level of open communication is the chief value of the law, and it is also the essence of why an aided death feels so diametrically unlike a clandestine suicide. One important aspect to be prepared for is what to do if you feel the patient does not qualify for some reason. Such patients find themselves limited to options offered in non-authorized states. In Oregon, we've come to deeply appreciate the value of staying legal, so we favor alternatives like palliative sedation or voluntary stopping eating and drinking, compared to any illegal and more clandestine approach. Both of these allow much better resolution of unfinished business with loved ones, family, and caregivers. Serious discussion about aid in dying with a patient significantly deepens the relationship one has with patient and family, and I really loved that comment from the Netherlands about why at the end of life it removes some of those standard social barriers that are necessary that we put up. By the time you've written a prescription, you've gotten to know them on a much more personal level. Attending a planned death is a deep opportunity for growth. The death is virtually always gentle and comfortable, but the relative suddenness of the transition from full consciousness to death can be a bit startling. On the occasion of my first patient's death, she said her goodbyes to her family, she drank her medication in one long gulp, and then she looked up with unmistakable pride. Her very last conscious emotion was her own pride in the accomplishment of her death. And those of us present had each helped her, and therefore we could share somewhat in that pride, and that's a remarkable and incongruous feeling at the deathbed of a loved one. You can switch the slide. There are specific illness-related issues that have been discussed earlier that can affect how well a patient can self-administer and ingest life-ending medication. ALS is a classic example of a disease where a mentally competent patient may have great difficulty self-administering oral meds. These patients have complied with self-administration by finding or inventing a way to initiate the flow of medication into a feeding tube. And perhaps the most frustrating situation is with people who have poorly functioning GI tract, especially if there's frequent vomiting. These people usually are unable to absorb oral drugs and therefore cannot use our law. And then the saddest circumstances involve progressive dementing illness in which the patient loses decisional capability long before they're terminally ill, and our laws do not address this situation at all. Voluntary stopping eating and drinking is the only legal choice for hastening death in that setting in the United States. Uh-oh. There are more slides, but... And they're pretty too, darn. I hope you get to see them. Incidentally, most of these are from the Northwest. One of them was from Patagonia, though. I'm going to just, yeah, there you go. After medication ingestion, unconsciousness occurs usually within minutes and death within an hour. But a prolonged dying process is more common than you might think. Early data of ours, early data that was collected under Compassion and Choices suggested that about 15% of patients are still alive after 8 hours, and 1 to 2% live more than 24 hours. An even smaller number, perhaps 1 in 200, might reawaken. This kind of outcome is more common with GI cancer involvement, with use of unusual prescriptions, with vomiting, or when a patient eats a large meal before ingesting the meds. In the Netherlands, where euthanasia is legal, oral aid in dying is also pretty common. It turns out that about 20% of oral aid in dying patients in that country receive some form of IV euthanasia, something like 2 or so hours after their ingestion. It's important for patients and families to understand the chance the process can take many hours and that reawakening is very unlikely but conceivable. In Oregon, when a dying process goes on for more than 8 to 12 hours or when vital signs appear to be strengthening, palliative modalities such as buccal morphine or topical fentanyl patches are sometimes used. This underscores the value in discussing this possible outcome with the patient and family in advance, and incidentally raises the question of whether legally, intentionally, and publicly ingesting a reliably lethal prescription constitutes some sort of de facto consent for palliative sedation if that drug fails to work as intended. There's been some talk about access issues, and they are real. Qualified Oregon patients desiring aid in dying may not be able to get the help they seek. Healthcare systems or individual doctors who opt out may force the patient to seek a new primary care doctor. And lack of care continuity is the single most frustrating aspect of aid in dying for patients and family. The current legal process is not too onerous when the usual PCP and relevant specialists are supportive, and under these circumstances, the time from first request can fairly easily be close to 3 weeks. However, it takes more like 2 months when the first request requires finding a new doctor. Where am I? Switch the slide. And switch the slide again. There. From a practical point of view, the safeguards in Oregon law are almost universally annoying to patients, but they are welcome to most prescribing doctors who value a waiting period and a checklist to ensure compliance. That said, there are potential tweaks to the current outline of all current laws that would improve access without compromising safeguards. And these could include, one is shortening the waiting period. This has been talked about a little bit, but I want to point out a detail, and that is that 15 days is a really weird number of days. And when your office hours happen every week, and when your patient's family is only off every Tuesday, it's almost impossible to make something like 15 days work. It would be a lot easier for it to be 14 days. Many would argue that 7 days is adequate for a universally mandated waiting period, especially since there's research suggesting that even 3 days of attitudinal consistency correlates with long-term reliability. At any rate, 15 days is a little unwieldy. It's always appropriate for a provider to require a longer waiting period in any circumstance if a decision is unclear. Interstate reciprocity is something we haven't talked about, but there's places, and maybe Portland's the most common one, where you have 2 states, both of which allow this, but people will maybe live in one state and get their medical care in the other state. In that situation, all of the activity and record keeping has to be around in the state where they live. And in our area, this aspect of the law is an unnecessary barrier to continuity. And finally, I'm going to comment though about evaluation of aid in dying as an ongoing medical practice. Many jurisdictions require some kind of registry and self-reported statistical information to somebody like Katrina Hedberg. That organization is not responsible for enforcement. It is critical to understand that medical aid in dying is a medical event. It occurs in a medically private space, but it's emphatically not a clandestine space. All healthcare providers, hospice volunteers, family members, and friends are aware of the event, and as with any medical practice, any one of these people can initiate a complaint to the state medical board, who could then have full access to all records. And there have not been any complaints like that registered in the last 20 years in Oregon. Thank you very much.